Hello, I'm Ileana Piña. I'm the quality chief for the cardiovascular line at Thomas Jefferson University and a lifelong heart failure transplant doc. I'm here at the ESC, and with me today is a researcher from Sao Paulo, Brazil, from the Institute of the Heart, which is a wonderful institution in Sao Paulo. I have visited them. And she is here to tell us about their work with reverse remodeling.
Thank you very much. I'm Deborah. I'm from Heart Institute. It's a pleasure to be here talking about our research, which is Carvedilol, a single maintenance therapy for heart failure with improved ejection fraction, the CATHEDRAL-HF trial.
So how did you come up thinking about that? How did you start?
In clinical practice, we always wonder if we have to maintain all medications for heart failure once the patient improves ejection fraction.
If they improve.
If they improve,
Yeah.
current guidelines, they recommend we keep all medications since the TRANSCRIPT trial, in which 44% of patients relapse dilated cardiomyopathy after suspension of all medications, signaling that probably these patients are in remission rather than a cure of a disease. So we have to keep some degree of neurohormonal blockade to prevent them from relapsing. So
If you know the etiology of, if it happens maybe from hypertension or something
yes,
else.
Some etiologies, we have to give medications for other reasons. For example, ischemic cardiomyopathy or hypertensive, they require antihypertensive. So maybe it doesn't change much, but we have patients with idiopathic dilated cardiomyopathy or myocarditis or pericardial cardiomyopathy, which are etiologies that may make us think if we can suspend or reduce medications lifelong.
So tell me about the structure of your study.
So what we did, we selected patients with reverse remodeling, and we considered patients with previous HFrEF, so left ventricular ejection fraction lower than 40%, and current LVEF greater or equal 50% with normal NT-proBNP less than 250 picograms per milliliter, without symptoms of heart failure, and using Carvedilol in optimized doses with ACE inhibitors or ARBs, and with or without spironolactone. And then we randomized patients in two groups, one to maintain usual treatment, and the other one to withdraw heart failure treatment, maintaining Carvedilol. So we suspended ACE inhibitors, spironolactone and furosemide, and then we followed both groups initially for 24 weeks, and then we extended follow-up for 52 weeks.
So it was still a highly selected
Yes,
group.
we excluded some etiologies of heart failure, such as ischemic cardiomyopathy, hypertensive, valvular, infiltrative cardiomyopathy, and patients with Chagas, which is common in Brazil.
Yeah, that's pretty common.
And patients with creatinine clearance less than 30, we also excluded.
So
and
you didn't want the CKD sick patients in there?
Yeah, but especially because these patients have the indication for ACE inhibitors or ARBs because they have proteinuria or another.
It's protective of the kidney anyway.
Yeah. So we excluded these patients.
Okay. So
we had a population with a median age of 55 years old, and the most common etiology for heart failure was idiopathic dilated cardiomyopathy in 60% of cases. And the left ventricular ejection fraction at diagnosis was 30% at the median, and the current LVEF was 58% in both groups, with NT-proBNP less than 100 in both groups, and a slightly reduced global longitudinal strain.
Those are low NT-proBNPs.
We included below 250, and the two groups, they had around 80 picograms per milliliter.
The NT-proBNPs that I see are thousands.
Yeah. So we really selected patients that were asymptomatic.
They had improved, obviously, at some point.
Yes.
Do you find that the NT-proBNP tells you that the patient is remodeling reversely?
We had the primary outcome, which were the recurrence of ventricular dysfunction, but we used one of the four criteria. Either one would be considered primary outcome. So either a reduction in LVEF greater than 10%, an increase in left ventricular and diastolic volume greater than 10%, an increase in NT-proBNP to above 400 picograms per milliliter, and a twofold increase, and clinical evidence of heart failure. So the patient, if they had either one, they would be considered primary outcome. And what we found in 24 weeks was that 3 patients in the intervention group and 1 in the control group had an increase in NT-proBNP, which is 10% and 3.7%. And one patient in the intervention group, one of these 3 patients, had also an increase in left ventricular and diastolic volume. The NT-proBNP increased before any possible changes in echocardiogram, which is different from literature. Usually we see echocardiographic changes before the NT-proBNP. So
I see the NT-proBNP go first.
Really?
Oh, yeah.
The interesting thing is that when the patient met the primary endpoint, we restarted medications as a safety measure, and then we followed these patients for this 1 year. And those patients who increased NT-proBNP were not the ones that worsened left ventricular ejection fraction in the future. Yeah. So we don't know if maybe this precocious increase in NT-proBNP was due to suspension of diuretic, considering maybe they required some degree of diuretic medications. We're not sure, but what we saw was that from the 4 patients that met primary endpoint at 24 weeks, only 1 really decreased left ventricular ejection fraction in the future.
That's pretty good. That's pretty good. So if you were going to tell clinicians what to do, what would you tell them?
I think the answer right now is to individualize. I think it's still too early to recommend suspension of medication. I think the point of this study is to open for future researches in the area. So probably
we have some work to do.
Yeah, I would say to keep the medications, and in individual cases maybe suspend and perform a close follow-up to see if there is any changes in biomarkers or in echocardiographic parameters. So I would be cautious about telling everyone to suspend medications.
So you got the NT-proBNP at baseline, and then you got it
at 12 weeks.
At 12 weeks, 3 months.
And then 24 weeks, and then 52 weeks.
So what would be the time period that you should see the lowest of the proBNP? Would it be at baseline?
We evaluated NT-proBNP at different time points between groups.
That's why I'm asking.
And the median value was similar between groups.
Didn't really change much.
Didn't really change much. These 3 patients in 12 weeks, they increased NT-proBNP. A 4th patient increased NT-proBNP in 24 weeks. And other 2 patients that worsened ventricular function at 1 year increased NT-proBNP. So the median value was similar between the whole follow-up, as well as the left ventricular and diastolic volume. And the LVEF was similar between groups, but at 52 weeks, it was slightly lower than at baseline.
So you didn't take anybody with that MREF 40 to 45 ejection fraction?
No.
So that's been excluded?
Yes.
Because you know, some of the SGLT2 trials have enriched the population with 40 to 49.
Yeah, what we did was trying to select mostly the patients that were
smart.
improved.
You got the real HFrEF.
Yeah, because
which is where you want to see it. So your longest patient now without the drugs is how long?
Oh, it's 1 year and a few months.
Okay.
It's doing
What's your next step? What are you going to do next?
We're going to follow these patients for longer periods, but we intend to perform a larger study with longer follow-up and using cardiac resonance and maybe genetic tests to better understand this population and see if we can find any predictor of worsening, because we see that a few patients will worsen in the future despite pharmacological treatment. So maybe if we select which are these patients we do not suspend medications in this group, and maybe the rest can use less medications in a safe way. So
I have found in my own practice that if the patients start doing something like drinking, it can raise their NT-proBNPs again and make them sick. So you may want to.
That's interesting.
That.
In fact, 2 of these 4 patients that increased NT-proBNP in 24 weeks, they started drinking. I don't know if it was for that, but
it happens.
Yeah, it happens. They had alcoholic cardiomyopathy, so probably that. But I can't say that it was a too small number.
I congratulate you. You were, you did a study that was sequel. One point after the other, so that you can really make a good reassessment. And thank you for being with me.
Thank you very much.
That's it for me with this group. I think it's so fascinating that we don't talk a lot about the improvement that we can make in pump function, and we can. And I think we need to continue to say that to the clinicians. Don't miss the opportunity to make your patients better, because some of them will change and we have researchers that are working on how to do it,
Yeah.
how to diagnose, and how to tell who isn't going to get better. Thank you for joining me today from the ESC. Have a great day.